Bismillah ar-Rahman ar-Rahim. In this presentation, I'm going to describe step by step a technique for endoscopic DCR. DCR in general can be done endoscopically or external or by laser. The external DCR is only absolutely indicated when we have trauma with medial canthal avulsion or when we are suspecting lacrimal sac diverticuli. Though this particular indication is amenable to be managed by the technique I'm going to describe. Of course, lacrimal sac malignancy is another absolute indication for external DCR. The advantages of endoscopic DCR include that we don't have external incision, the anatomy is better visualized, and the swelling postoperatively is minimal, and can be done in presence of active infection, and the instruments used are minimal and available. At the same time, we can correct any intranasal pathology detected preoperatively. The main advantage of endoscopic DCR is that the bleeding is less, success rate is comparable to the other technique, maybe better than the external one, and it doesn't need sophisticated instruments, and the external scar is prevented. In addition, the orientation I'm going to show is very beneficial and can be learned with a very steep learning curve. The preoperative evaluation will depend on ophthalmological and otolaryngological examination. The regurg test is helpful. Probing to detect hard stops is also very beneficial. The detection of a distended sac is a sure sign that we have distal obstruction. Syringing with mucoid material output is also indication of distal obstruction. The examination also detects any associated pathology which need to be addressed during the procedure. Lacrimal probing is a very critical step either in the diagnosis or in the intervention. In our technique, we don't use any lacrimal or punctal manipulation, and we don't use stents, which prevent the drawbacks of using these techniques. Probing and any lacrimal punctal manipulation should be done under magnification and with utmost care not to injure the punctal region. Sophisticated radiologic investigation like the dacryocystogram or lacrimal scintigraphy is helpful to detect level of obstruction and to detect whether a tight common canalicular pathology is contributing to epiphora, which needs special attention. CT sinus is also helpful to detect any concomitant sinus disease. The indications of DCR is when we have symptomatic epiphora due to nasolacrimal duct obstruction or due to dacryocystitis, or when we have to resect the duct as part of other surgical intervention. It is not solely indicated where the site of obstruction lies in the canalicular or puncti. In case of functional obstruction, which can be detected preoperatively by the evidence of free flow, despite that the scintigram showed that there is no functional drainage of the sac. This is the only added value of scintigraphy in the preoperative investigations. We have to exclude perisacral stenosis. Probing can do it very effectively, and as we mentioned, it has to be done under magnification to avoid damaging the punctal area. The fluorescence dye test and other types of cystographs are only very selectively indicated. In this particular technique, it has main advantages and clear features, which needs to be clearly demonstrated. That in this technique, we depend on the concept of lacrimal sac and lacrimal duct decompression. It is wide exposure of the nasolacrimal duct and the sac at the same time. It is not only making a window overlying the sac region. The nasolacrimal duct is identified first, and then it is followed superiorly to reach the area of the lacrimal sac. The common canalicular location is helpful as identifying a landmark to denote that we reached the upper surface of the lacrimal sac. We don't do any punctal manipulation, and we don't use stents post-operatively. The first step in the technique is to identify the important landmarks like the maxillary line, the axilla of the middle turbinate, the agarnazi cells, the uncinate process, and the inferior turbinate. Anesthesia, we use general anesthesia for the procedure with injection of lidocaine 1% with 1/100,000 epinephrine as injection, and we use vasoconstrictive surface decongestion using cotinoid or myrocell soaked in the epinephrine. We have to avoid unnecessary manipulation of the endoscope and the instruments during packing, and we have to avoid mucosal trauma, especially to the area of the middle turbinate. If septoplasty is planned, incision on the site contralateral to the DCR is advisable to avoid scarring or fibrosis. The application of surface anesthesia and injection is used with gel foam or myrocell or cotinoids to have gentle manipulation of the surface in order to avoid induction of bleeding. Injection, we inject along the prominence of the lacrimal sac and duct. We inject the maxillary line and the axilla of the middle turbinate, and sometimes we inject the upper surface of the inferior turbinate. The second step is to make a rectangular flap based posteriorly overlying the lacrimal prominence. This is done by making two cuts, parallel cuts. The first cut is above the upper surface of the inferior turbinate of about 2 centimeters, reaching short of the nasal vestibule to avoid damage of the cartilage of the nasal skeleton. This is the first cut, the inferior one. The upper one is about the same length, 2 centimeters, and it starts 1 centimeter above the axilla of the middle turbinate. And these two cuts are connected vertically by rounded knife or by the suction dissector, and we expose the bone overlying the lacrimal prominence till the area of the lacrimal prominence posteriorly. It is very important to expose the area completely and to control bleeding if it is there. This is the mucosal flap initially created. Then, after we expose the bony prominence of the lacrimal system, this is the area of the nasolacrimal duct and the sac above. This is the mucosal flap. We remove the bone in a very convenient way by bone cutting plexly or punch, like the Carrison or the Koffler punch. Of course, we can use the lacrimal drill, but actually there is no need for it. Then the lacrimal bone is removed starting inferiorly, and this is a major difference between this technique and the other techniques described. We expose first and identify the area of the nasolacrimal duct above the inferior turbinate, and when we identify it, we follow it superiorly, removing all the bone covering the lacrimal duct and the sac. And at the same time, we are not just removing a bony window, we are decompressing the whole system. We remove as much bone as feasible in order to have complete decompression of the system, which allow us to make mucosal flaps and to have a very minimal possibility of having post-operative stenosis or restenosis or fibrosis. So this is the area of the nasolacrimal duct. We are following it superiorly. This is the area of the lacrimal sac. We are removing all the bone covering it from 270 degrees in 3 directions, exposing the lacrimal sac. And we end by having a very clear vision and identification of the lacrimal duct and the lacrimal sac area. As I said, we remove bone as much as we can from the anterior, posterior, and the medial aspect of the sac. This is the area of the sac very well delineated and identified. After that, we incise the lacrimal sac, starting not only at the lacrimal sac level, but we start our incision at the nasolacrimal duct area, and we'll go superiorly to open the full length of the lacrimal duct and the sac. and we open the lumen of the sac by extending the incision superiorly. And after that, we inspect the inside of the sac area, and then we make two flaps, and anterior and posterior, in a book manner, and we use this saccal flap to cover the raw area around the stoma to prevent raw area and fibrosis of the region. We make two cuts, either in the posterior flap alone or in the anterior and posterior flap, and we adjust the mucosa of the lacrimal sac to cover the area surrounding the stoma. After that, we inspect the inside of the sac to be sure that we opened it completely. This area is very important. This is the opening, the medial opening of the common canaliculus from the medial side, and it indicates that we reached the upper part of the lacrimal sac. When we inspect this region, it is easy to identify it anatomical, and sometimes there is some secretions coming out of this region. We can do the ballotment test, and we can inject, if we are irrigating fluid from the punctum, we can identify the fluid coming out of the area of the common canaliculus. We can do manipulation also to dilate this area if it is predetermined that it is involved in the stenotic process. After that, the mucosal flap, initially raised, is transversed by transverse cut to divide it into two flaps, superior and inferior. The upper flap is used to cover the upper surface of the field, and the lower flap is used to cover the inferior part, keeping in mind that we have to leave the area of the common canaliculus from inside patent in order not to hinder the drainage of the lacrimal system. Then we stabilize these two flaps by additional gel foam, which are used also to control the bleeding if there is bleeding, because we don't depend on packing or any additional stenting of the system after that. So the main advantage and the key success points in this technique is that we are not following the traditional teaching of having a bony window overlying the sac. We don't leave any raw area. The medial side of the common canalicular opening is detected and inspected and can be manipulated at the same time. If we have extra lacrimal anatomic obstruction, this can be addressed at the same time. Very important to remember that in the older technique that we use the probe to identify the area of the sac, and we open above the probe. In this technique, we don't do this, and as we don't need it because we follow the the lacrimal duct region inferiorly and trace superiorly to reach the area of the lacrimal sac prominence. There is no doubt about the orientation. We are 100% sure that we are following the anatomy, and we are decompressing the system, not only making a window above it. This is the area of the nasolacrimal duct above the inferior turbinate, which is followed superiorly till we expose the lacrimal prominence, and we decompress the lacrimal system from three sides, as I mentioned. So in this technique, just to summarize what is the concept of it, we depend on the bone removal from inferiorly, which is followed superiorly to trace the lacrimal sac area. We don't do probing and we don't do stenting post-operatively. This is a very important starting point, and it has to be followed in this order. The stenting and the punctal manipulation, actually it is known that when we manipulate the punctum, there are potentially many hazardous side effects. The pump action is disrupted, the puncti may lacerate, and the capillarity are lost. And if we apply tight stent post-operatively, cheese wiring may occur, which affect the functional effect of the whole system. Thank you very much, and thanks for the organizers and the organizing committee. Thank you.